Maza has been operational for about a year and a half now. We started in Chereponi district in December 2015. We've been there since then. We launched this year in the second district, Bunkrubu, also in northern region. We launched in April 2017. So we've had about 3 months experience in the second district and about a year and a half in the first district. For Chereponi district, we started with a model that was dependent on a subscription system for the pregnant women. Essentially, we would meet them in the clinics when they came for antenatal care to find out what their plans were for when labor started. Are they planning to deliver at home or planning to deliver in the hospital? If so, what's their transportation plan and how are they going to get there? And this is part of what Ghana Health Service does anyway with the pregnant women. So we try to layer on an existing system. Based on what they told us about their transportation plan for when labor started, we would introduce Maza's model. Our drivers are available with the motorized tricycles. We have a toll-free number. When they're in labor, they can call us. Our drivers will take them to the hospital. We are very keen to develop a financially sustainable model. So we didn't want to provide the service for free. We wanted the families to, if they want to go to hospital, they value delivering in a hospital, we wanted them to pay a small amount, not necessarily at profit, but just enough to cover the cost of fuel for the drivers. So we were proposing, something fairly small, like 10 cedis or 15 cedis or 20 cedis, depending on the distance. And we wanted them to start saving ahead of time. Since we're seeing them about maybe 3 months or 4 months of pregnancy, they would have several months to save a small amount over time, so that when labor starts and they call us, it's not then that they're running around looking for money to pay us. That was our thinking. And we thought that one way to ensure that the money was there is by using mobile money. Save the money on your mobile phone and just leave it there. When labor starts, you call us, you send the money to us, and we bring you to the hospital. However, as we started implementing the model, we learned quite a few things about the communities that were serving the pregnant women and some pregnant women and some of the families' attitudes around saving, around mobile money. And I think on that note, it's probably better if Genevieve tells us some of the lessons we learned in Chereponi.
Some of the lessons that we learned in Chereponi was that we subscribed the pregnant women at the facility level, as Nana rightly said, and it was individual. We meet you, then make a follow-up to your community. Then also they were to pay for transportation as well, and we realized that they went to the hospital anyway, but a few of them used a motor tricycle to the facility. So in order to know where that cause was the problem, in our new district, what we did was to engage the entire community right from the beginning, which includes the men, because they are the sole decision makers in the community household level. So we involve the whole community, the opinion leaders as well, and give them the health education in order to sensitize all the communities. Whereas in Chereponi, we were specific with the subscribers. Then with regards to the transportation, in Chereponi, they were to pay for fuel, and we realized a few of them use them. So in Bunkrubu, what we did is that right from the onset, we communicated clearly that transportation to hospital for a group of people, pregnant women, who are sick, pregnant women in labor and sick infants, were free. And we realized that we have, just for this past 3 months, we've had more than 100 emergency cases. Whereas in Chereponi, in 3 months, comparatively, it wasn't up to that number.
In the first district, we realized that the amount of money that the families were able or willing to save was so small or non-existent. Rather, they wait for the crisis to happen. I guess this is typical of our culture in Ghana. People wait for the crisis to happen and then they start looking for the money. It might take an hour, 2 hours, etc. And they're looking for the vehicle. The challenge with that is that when you have a medical emergency, like a complication during labor or a very, very sick newborn, you don't have 2-3 hours to waste looking for money, looking for fuel, looking for a vehicle. So we decided that in order to keep things effective, efficient, and simple, let's eliminate the price for the pregnant women and the families altogether. Let's provide that service free. but then focus our revenue generation model on the drivers, because at the end of the day, the drivers are able to use our tricycles to make money. They take women to markets, they carry goods from people's farms to their homes. So 5 days a week, or sometimes even more, our drivers are making a decent amount of money. So they're commercial agents. And then 2 days a week, they use our vehicle to transport women, pregnant women in labor, or sick people. So we decided that for our second district, we'll focus more of our efforts for revenue generation on our drivers. Figure out a way to get them to pay us more money over time so that we can be sustainable through that model, and rather provide the service to their families for free. So maybe Winnie can talk a little bit more about the driver, our relationship with the drivers, and how we're working towards financial sustainability.
Regarding the drivers, what we learned from Chereponi was that in Chereponi we got a recommendation from the Ghana Health Service, which are our partners. And based on that, we use facility-based volunteers as our drivers. But we had so many challenges regarding repayment, community ownership, and buy-in. So learning from that to Bunkrugu, we had the stakeholders engagement. We engaged the district opinion leaders, partners. We engaged the community chiefs, elders, etc., and they selected the drivers from the communities, helped us with the interview. They were actually part, and we selected the final candidates for the drivers, hoping that if we run into difficulties with the drivers, we will go back to them. They hold them responsible because they did the selection. They are in the community, they were from the community, and they are working for the community.